Hi there. Can you see and hear me okay?
We can see you.
All right, great. Well, welcome everyone. I'm glad to see so many people in the audience, and I anticipate there'll be a lot of folks that will be viewing this probably later once it's recorded. So the benefit of being here live in person virtually is that you get to ask questions. And actually, in my experience doing these for some time, that's usually the most valuable thing rather than me talking for an hour is that I'll talk maybe for 15 or 20 minutes and then really just kind of open it up for discussion. There's no such thing as a bad or a dumb question. Everyone has questions, and many people are probably thinking the same thing that you are and are glad that you asked it. So feel free to do that. I am going to share my screen. I just have a couple slides to guide the discussion. And if you can just let me know if you can see the screen,
Looks
Dalton.
great.
Okay, great. So the topic that was asked to discuss is a little bit of a niche topic, which is secondary cancers or malignancies in patients with CLL or SLL. So the term secondary really just means second or other cancer. So even though you have probably if you're here, you have CLL or the a similar basically identical condition of SLL. And many people wonder, if I have this, is that, what does that mean for other things that can go wrong in my life? And uh, I wish I could say it gives you the free pass for nothing bad ever happening, since you've already had the misfortune of having CLL. But the good news for CLL patients is that the survival of patients with CLL is really getting closer and closer to the general population. And by that I mean 10 years ago or more, maybe 15 years ago, when I started doing this, if you just sort of looked on the internet and Google searched what is the life expectancy of someone with CLL, you might say like 7 years or something. And that was really, I think, a doomsday, an old, outdated sort of view of the world. And more importantly, we know that over the past 10 years, the expected survival of patients with CLL keeps getting better. And it keeps getting better to the point where it's similar to the general population. So, um, for age, what we call age-matched controls, the survival of CLL patients is closer and closer to those without CLL. And the real reason for this is that the treatments that we have are so much better than they used to be. They're more effective, they're less toxic. So that's all good news, and that's a topic of discussion we could have for hours about all the treatments and things that we can do to make CLL more of a chronic condition rather than such a doomsday event. So that's great. So what does that mean if you have a longer life? Well, other things can happen. There's more opportunity for things to go wrong, more opportunity for accidents, car accidents, other diseases, other cancers. And so, what are the other things that can happen? Most of them in patients with CLL result from a deficiency or a weakness of the immune system. And this immunodeficiency is inherent. In other words, once you have CLL and you have these clonal B cells floating around in the bone marrow and blood and other places, they impact the other good, healthy parts of the immune system, particularly T cells, which are, again, another component of the immune system that is involved in immune surveillance. And T cells look for viruses and infections. And if they're improperly functioning or not enough of them, you can get increased risk of infection and other cancers because it turns out that T cells are also on surveillance looking for um, the sort of early cancer cells in all parts of the body, and their job in part is to eliminate cancer cells before they can turn into overt cancers. And the other part of this is that the treatment itself historically weakened the immune system, particularly in the chemotherapy era. We don't really use a lot of drugs like fludarabine or bendamustine anymore, but those are pretty immunocompromising in their nature. So both the disease and its treatment historically can impact immunodeficiency. So the guide for today is really just this one slide. We'll go through each one. So what types of cancers can patients with CLL can get? Skin cancer is the big one that we'll talk about. And then what we call traditional solid tumors. So breast cancer, lung cancer, colon cancer, prostate cancer, all of those things can happen, maybe with a little bit more increased frequency, but even if your frequency isn't really that much more increased, they still can happen, just like they can happen to anyone. And then, oh, my numbers got a little, I have two number twos. So the second number two is secondary hematologic cancers. We'll talk about those. Those are fortunately becoming less common. And then the dreaded Richter transformation that you may have read or heard about. We'll talk a little bit about that condition. So why do we push skin cancer, skin cancer, skin cancer as the really should be the top three of these? This is really the one that clearly CLL or SLL is a major risk factor for skin cancer. And when we talk about skin cancer, there's melanoma and then there's non-melanoma. So the non-melanoma is the type that we typically see in patients with CLL. There's squamous cell carcinoma or basal cell carcinoma. The main risk factor, of course, for all skin cancers is direct and prolonged sun exposure. So the sun has this double-edged sword that we all love it and we all worship the way it makes us feel, and it does contribute to feelings of sort of satisfaction and contributes to well-being. Obviously, we need some sun exposure to generate vitamin D, which is important for many aspects of health. But the problem with too much prolonged sun exposure is when you get burns that can happen in as short as 20 minutes of prolonged exposure, particularly on days with high UV index or in tropical climates. So the main things that you can do to prevent these skin cancers from occurring is the simple measures of avoiding prolonged exposure to the sun, wearing sunblock, hats, long sleeves. So it's a little bit of a mixed message, I realize, because we just got done talking about how the sun is beneficial in moderation. But really, for people who haven't had a skin cancer and have CLL, it is really something to be really aware of. And what can you do about it? Well, probably if you have had a skin cancer of squamous cell or basal cell, you really need to have at least every 6 or 12 months a full skin exam with a dermatologist. If you haven't had one yet, you probably will. It seems like everyone has one by the time they hit 60 or 70 years old. So just any suspicious new lesion that or spot on particularly the face or arms or legs, anywhere that gets a lot of sun, if you're concerned about it, you can always start with your primary care doctor or your CLL or hematology oncology doctor, and then a referral to a dermatologist for a biopsy. And usually these are manageable with simple surgery, simple resection. They can get kind of big and sometimes require what we call wide margins. I have had patients who've had to have skin grafts to cover up the kind of big area that was removed. And if you need that, then you probably need to go to a larger center that has plastic surgery expertise in skin grafting. But for the most part, I think of these more as a nuisance than a huge threat to one's health. But there are, some cases of patients who can have spread of squamous cell carcinoma to lymph nodes or other spots that do require more than just simple surgery. Again, this is uncommon, but if it does happen, it tends to happen more in patients with a compromised immune system. So I'll just go on through the full slide deck here, and then hopefully if any of these topics are prompting questions, feel free to jot them down and we'll circle back. So the other one kind of major group of second cancers that we can see are the traditional solid tumors. So the big four would be breast, lung, colon, and prostate. This actually, if you just look at these four cancers, this comprises the majority of cancers in the United States. So that's, the risk of getting one of these with CLL is only modestly increased, unlike skin cancer. It's not a huge risk factor. So really, the good news is that for all of these, there are very well-established screening tools that are available for patients that really any adult over the age of 50 should be getting annual mammograms. Anyone with a smoking history should be getting low-dose CT for screening for pulmonary or lung nodules. Colon cancer is screenable with colonoscopy every 10 years, or now there's other tests, non-invasive tests that look for early signs of colon cancer. And then for men, prostate cancer screening can involve PSA blood test and referral to urologist if there's suspicious findings. So what I would say is the current recommendations for CLL patients are not any different than the general population. But for men and women, there are screening tests for all of these solid tumors that should be done on a regular basis with your primary care doctor. The third one is secondary hematologic malignancies. These really are less common now in the era where we're not using traditional, what we call DNA damaging agents. So the way that medications like fludarabine, cyclophosphamide, bendamustine, all the traditional chemotherapy drugs that are used historically were used for CLL can increase the risk of damage to the bone marrow. This can result in a condition called myelodysplastic syndrome, or MDS, which can evolve into a frank AML or acute myeloid leukemia or other conditions. So what can we do about this? If you have happened to, if you were diagnosed and treated maybe 20, 15, or 10 years ago, and you've received one of these, it's still a relatively low risk. What I would say is there's no clear preventive strategy to lower that risk at this time, but it should be maybe considered on the list of possibilities or so-called differential diagnosis. If you have abnormally low blood counts for any reason, then a bone marrow biopsy may be warranted to look into that. So again, we hope to see fewer of these as the time goes by and we go deeper and deeper into the modern era of targeted therapy where the traditional chemotherapy exposure is less and less. And then kind of the final one is the Richter transformation. If you've read about this, it's obviously something that sounds concerning. The typical presentation for Richter transformation is a rapidly enlarging lymph node that's sort of disproportionate to the size of the other lymph nodes in a patient with CLL or SLL. Most commonly, this does require a tissue biopsy of an enlarged lymph node that may be directed after some imaging studies, such as a PET scan, to determine, if there are lymph nodes that are really what we call hypermetabolic or highly metabolic on PET scan imaging. So if you have had CLL treatment in the past and have a enlarging lymph node, this is something that um, should be at least considered. It's still rare. The incidence is about 1% annually. So if you have 100 folks with CLL and a year goes by, you would expect maybe one case of Richter's. But if you have, 100 people and 10 years go by, that means you might have 10 cases. So we do see it. If you see enough patients with CLL, you will see it. The treatment for it is tricky. It does depend often on what treatments have been administered previously for the CLL, if any. And sometimes advanced maneuvers like stem cell transplant or CAR T cell therapy are recommended. So don't want to dwell too much on the treatment for Richter's, but that is something sort of on the list of things of second cancers that can take place in CLL patients. So as promised, I only spoke for about 20 minutes. I'm gonna pause now and see if there are questions. I think you can unmute your microphone if anyone wants to be brave. Feel free to do that. Otherwise, we can go to the chat. I see one question from the chat. Are there specific dermatologists that are recommended to look for skin cancer? Yeah, so dermatologists typically are very familiar with skin cancer. It's probably a large part of most of their practice. Maybe if a cosmetic dermatologist might not be doing a lot of that, but a general dermatologist would be very comfortable diagnosing and managing skin cancer. If it's a lesion that is biopsied and found to be like a basal cell, there are specific types of surgeries called Mohs surgery that does require some specialization. So if the dermatologist you're seeing doesn't perform Mohs surgery, he or she will likely refer to a Mohs trained surgeon to make sure that they resect the so-called margins or the edges of the tumor cells, and they check that during the procedure. It's usually an outpatient procedure, but sometimes can take several hours because of the requirement to check each time under the microscope to make sure that the lesion is completely removed. So hopefully that answers that question. Are there
And
other, go ahead.
one that I've gotten from people that pre-submitted questions is, does having CLL make it harder to fight off these secondary cancers, for instance, a breast cancer?
Yeah, I would say for squamous cell carcinoma, it probably does. And again, surgery resection is the traditional and most common, like sort of the mainstay of treatment. That usually, in the vast majority of cases, is effective. I have unfortunately seen a few cases over the years of metastatic squamous cell carcinoma that can spread to lymph nodes. Then that does require chemotherapy or other immunotherapies and systemic treatment. It's probably is harder to treat in CLL patients because of that. But the other more common, the breast cancers and the colon cancers and the others are, it's not clear that their outcome is necessarily worse in CLL.
It's good to know. And then let's see. We do have another question about Richter transformation, just kind of things to be on the lookout for when it comes to Richter's.
Yeah, so Richter's is something that is usually not very subtle. In other words, when we really worry about Richter's, what we often will see is the typical symptoms of aggressive lymphoma, which could be characterized as sometimes referred to as B symptoms. So drenching night sweats, not just a little hot under the covers at night, but really drenching, happening most nights, if not every night. Unintentional weight loss, severe fatigue, to the point where it's really difficult to function. Losing weight, yeah, again, unintentionally, more than 10% of your weight. So for, let's say someone weighs, 150 pounds, if you lost 15 pounds, that would be a 10% drop unintentionally. That would be really noticeable. People would notice, maybe decreased appetite and severe fatigue. And then often, people will have, again, rapidly enlarging lymph nodes that can be felt if they're lymph nodes that are in the areas that can be felt, like in the neck, armpits, groin area. Sometimes the lymph nodes can sort of hide in the abdominal cavity. So-called retroperitoneal lymph nodes can actually get pretty expansive without really feeling them from the outside, but the symptoms of that when they expand quickly may be sort of unrelenting back pain, bloating, abdominal pain. Those are the types of things that if you're experiencing those kind of red flag pain symptoms, like waking you up from sleep or unrelenting, those are things that would probably warrant getting CT scans to evaluate. Um, and hopefully that answers that question.
Yeah, I feel
Um,
like that's a good answer with that one. And I did want to just share, I'm going to post a link in the chat here in a second.
okay.
I did a webinar on Richter transformation with Dr. Aaron Perry
Oh,
from
good.
Dana-Farber.
Oh, yeah.
So if anyone's interested in learning more about Richter, we do have that resource. I just put that link in the chat there. So if
Okay.
anyone wants a deep dive, that one went pretty deep into the topic. So
So there is another question in the chat. Is there an increased risk of overdiagnosing or over-treatment from mammograms if you have CLL? That's a great question. What I would say is if you're getting regular like hopefully if you're getting annual mammograms, there's a baseline to compare to. So really any new breast lesion really should be pursued according to the normal algorithms that are pretty well established. So usually if there's an abnormal lesion, an ultrasound may be recommended and maybe a needle biopsy. And if it is a breast cancer, it really needs to be appropriately dealt with and so forth. What I have seen is that for some patients with CLL, they do have enlarged lymph nodes in the armpits, so the so-called axillary lymph nodes, which is also a site where breast cancer can spread into the armpits or axillary station. So I have had patients, actually, I have had patients who were diagnosed with CLL, SLL based on mammogram that found a lymph node in their armpit, and the biopsy showed CLL, SLL. But once you have armpits in lymph nodes in your armpit and you get mammograms, it'll show up on the reports frequently as enlarged lymph nodes. So that's where really having a conversation about the findings and follow up with the ordering provider to make sure they understand that these lymph nodes are most likely CLL, SLL. If there's some concern that they could be a spread of a breast cancer, that a biopsy, needle biopsy may be indicated. But without a lesion in the breast, it's unlikely that enlarged lymph node would be metastatic breast or spread of the breast cancer. Again, you have to have a tumor in the breast for that to start. Um, so let's see what other questions. Maybe I'll ask for some guidance on which of the other questions we should do here.
yeah, I think that this is a good one. So this individual is on they stage the chemotherapy with zanubrutinib.
Uh-huh.
Does that are there any known um, correlations with these more targeted agents and secondary cancers?
Yeah, so the answer is probably not. So when the first BTK inhibitor, ibrutinib, was introduced over 10 years ago, there were a number of patients who had previously been treated with chemotherapy drugs, maybe with repetitive cycles or rounds of therapy, and were really having a hard time controlling their CLL. And then they started ibrutinib, and soon after that, we found that some of those patients developed Richter's transformation. Um, at the time, there was some discussion in the field. Does this mean that the ibrutinib was causing it? And I think that we've settled on pretty clearly not. In other words, ibrutinib, acalabrutinib, zanubrutinib don't cause Richters. And in people who haven't had prior CLL, the data are pretty clear that the rate of Richters um, in patients who are on a BTK inhibitor, for instance, like zanubrutinib, has not gone up or down compared to the historic kind of 1% range that I quoted. And in terms of other cancers, no, it's not. There's no data of all the thousands of people who've been treated with BTK inhibitors over the past decade. I think by now we would have seen a signal. If it was causing some other cancer, we would have that would have been observed, and it simply hasn't.
Mhm.
So I think based on the current available data, the kind of that risk is probably that probably doesn't exist.
Okay. And then a follow-up question came in from that one, and I would just love if you could clarify this one for the community because I know there's some confusion around this. But
Yeah,
is zanubrutinib, BTK inhibitors, are those considered a form of chemotherapy or are those immunotherapies?
yeah. So the term chemotherapy is a little bit of a loaded term because it typically has a negative connotation, and usually what people are thinking about when they use the word chemotherapy are again the kind of non-specific kind of cellular damaging poisons that poison or kill the cancer cell and can affect the good cells. So a drug like fludarabine or bendamustine would be in the traditional chemotherapy category. Um, the term we often use for drugs that block BTKs, the so-called BTK inhibitors, I like the term targeted therapy. Now, it is a systemic medication that treats cancer. So if you define systemic medication that treats cancer as chemotherapy, then everything we do is chemotherapy. But I think it's best to kind of categorize traditional chemotherapy drugs and separate that from targeted therapies. And then immunotherapies would be kind of a third group of systemic treatment. Immunotherapy, the best sort of example would be like antibodies like
Mhm.
Rituxan or obinutuzumab, which they are targeted, but they kind of work rather than blocking individual switches inside the cell, they work by recruiting the immune system to eliminate the cancer cell. So it's a little bit of nomenclature, but I would typically call zanubrutinib, acalabrutinib, ibrutinib, venetoclax, all those as targeted therapy.
Okay, good to know. And then let's see. There was one that I scrolled past here. When a person is on treatment, does that make it more difficult to find these secondary cancers? Maybe some side effects?
Yeah. Um, I think the tricky part with finding these second cancers in someone on treatment is that sometimes the areas of the CLL or SLL can be confused for other cancers. So the example of the patient getting the mammogram who has an enlarged lymph node in their armpit, it's probably the CLL, SLL. But could it be a breast cancer that spread there? Or for instance, if you have CLL, SLL, and you have lymph nodes or growths in your abdominal cavity, and let's say that, one of them maybe is near or on an organ, like the kidney, for instance, could it be assumed to be CLL, SLL, but it's actually a kidney cancer? Those type of confusing pictures are something to be aware of. But once you sort of identify an abnormality and you're on treatment, usually we would expect all of the areas to get smaller and respond to treatment more or less equally. But if you had all the lymph nodes shrink, but one mass or lesion in some other organ getting bigger, let's say on a CT scan or some other test, then that would be a cause for concern that maybe we're missing a second cancer or a transformation event. And whenever there's uncertainty, it's probably best to get a biopsy, a needle biopsy, which usually can be done in a minimally invasive way and not require major surgery.
And then, or we have another question coming in of what are the indications to start treatment for CLL? So I know this isn't totally on this topic, but it's
Yeah,
a
sure. We
question
can
that we
talk
want to
about
know.
those. Yeah. With CLL, probably most in the audience are familiar with the term watch and wait, or I prefer the term active surveillance. For patients who have no symptoms and normal blood counts other than the white count, it's the international standard is to watch and wait or do active surveillance. So the white count can go up. You can have a white count of 20,000, 30,000, 40, 50, 60, 80, 100. The white count can go up, and it probably will, and it's expected with time that it will rise. it, the white count going up in and of itself is usually not the reason we're starting treatment. Usually, the reason that we're starting treatment is one of two things. So, number one would be symptoms. So, if you have symptoms, the things like the drenching night sweats, bloating, severe fatigue, those would be a reason. Symptoms from enlarged lymph nodes would be a reason. And then the second reason would be if the blood counts are changing in regards to the red blood cells or platelets. So hemoglobin is how we typically measure the red blood cell level. If it's dropping as the white count's going down, that's called anemia. And if you get more anemic, the hemoglobin getting from 13 to 12 to 11 to 10, as that goes down and the white count goes up, that's a sign that the bone marrow is having a hard time producing the red blood cells. So the internationally accepted threshold for initiation of treatment is a hemoglobin less than 11. Um, if you're 10.9 and you feel fine, do you have to treat? No, I would say depends more on the trend and maybe some symptoms could figure into that. And then platelets, again, are made in the bone marrow, but as the white count rises, if the platelet count starts going down, the threshold that's kind of agreed upon based on international consensus guidelines is a platelet count less than 100. So again, if you start off with a normal platelet count of, let's say, 200, and then it goes to 170, and then it goes to 120, and then it goes to 99. Uh, Technically, when you hit 99, that's when you would start treatment. But it really depends more on the trajectory. If it's clearly going down, that's probably a time to start. So symptoms or blood count drops with red blood cells or platelets.
Okay. All right. And then I'm trying to see. I don't see any more questions coming in. If anyone wants to unmute, again, you are free to do so and ask a question. But if not, we will start wrapping up here in a second. But I guess just if you could give one takeaway for the audience, if they're going to hold on to one thing from this, what would it be?
Well, I think that everyone's here or watching because they're trying to be an active participant in their healthcare, which is wonderful. Uh, when you go to see your primary care doctor, you may be, more attuned to some of these topics than your primary care doctor. Not with any disrespect to your primary care doctor, but they may not be thinking about CLL on a regular basis, even though they probably do have CLL patients in their practice. So, you know, the things like we brought up today, like the skin lesions, again, if you haven't had a skin cancer, there may be one in your future. And the only real way to know if you have one is to kind of bring it to the attention of your healthcare providers. So yes, you can refer yourself to a dermatologist, but it's also good to see your regular primary care, once or twice a year. And, if you have a concern about your skin, I would definitely let your primary care take a look. There are a lot of pretty common skin disturbances that are not skin cancer. So usually those can be sorted out. But if there's any concern, I would have a low threshold for a visit to your local dermatologist for a skin exam and possible biopsy. The other ones that we talked about, the solid tumors, again, for men and women, there's well-established screening tools that are well worth doing. For people who have a smoking history in their past, there is a lung cancer screening loaded for pulmonary nodules, a CT scan of the chest that is recommended. If you don't have a smoking history, you probably don't need to do that. But certainly for mammograms and colonoscopies and PSA tests, there's pretty established tools. And then the other ones really mainly the Richter question. That's probably going to be a question not for your primary care, but for your treating oncologist. And being aware of these symptoms, I think patients typically know their body's best, and if you know or feel something really different, again, like the bloating or the pain or the B symptoms, and you be sure to bring it to your treating hem-onc physician, bring it to their attention so that if you have an enlarged lymph node, if they haven't considered Richter transformation, that maybe that could be considered by or entertained by getting a tissue biopsy.
Right. And then we did have a new question roll in as well as a comment that I want to speak on first. Alejandro pointed out that today is World Blood Cancer Day, and he
Oh,
just
wow.
wanted
Okay.
to
Well,
congratulate all the survivors here. So
okay, that's great.
yeah. And then the question that came in is there a larger risk for secondary cancers if they have a TP53 deletion or any other genetic mutations?
Yeah, so 17p deletion or TP53 loss or mutation is typically something that's confined to the CLL cells. So it shouldn't have any impact on your other organs and their risk for other cancers. The exception is a pretty uncommon hereditary cancer syndrome called Li-Fraumeni syndrome, in which patients have a defective TP53 and typically have multiple cancers and strong family history of cancers early in life. So that would be an exception that would require probably referral to a genetic specialist. But in the average CLL patient with the 17p deletion or TP53 mutation, this is something that's just confined to the CLL and really shouldn't have an impact on other risk of other cancers.
Okay. All right. And it looks like our questions are done. So we're going to go ahead and call it there. So
Okay.
thank you, Dr. Hill.
All right.
That was super informative, and thanks for doing such a great job of answering all of these questions.
Thank you.
It was
My
such a
pleasure.
pleasure to work with you.
My pleasure. Take care, everyone. I'll
Yeah.
let you finish up here.
All
If
right.
Dalton, would the doctor be
Yeah.
able to look at my question about the abdominal mass? I added that at 10:39.
Yeah. Sorry, I
Oh,
may
yeah.
have missed that one.
Okay.
Maybe you
All
could
right.
share. uh, So it was the 15 centimeter abdominal mass. So you probably had symptoms for this, I'm guessing, and then it was removed. And then was that how you were diagnosed with CLL, or had you had it
No,
before?
I'd had CLL for quite a while, since 2011 I was diagnosed, and the surgery
Okay.
is 2023.
Okay. Yeah, so that's pretty big to get. I mean, it's not out of the, it would be a little uncommon to get that big without having symptoms first. And if there is an enlarging abdominal or lymph node or mass that is not clear what the diagnosis is, then surgery to biopsy it is usually indicated. It doesn't necessarily always have to remove the entire thing. Depending on the complexity of that surgery, it may be easier just to sample it with a needle. And if it's CLL, then really the treatment would be, again, the systemic therapies that we've talked about rather than like surgical resection.
Okay, thank you very much.
Of course.
Cool. And thanks for pointing that one out. I just may have missed that. So thank you for catching that for me. All right. And thank you again, Dr. Hill. Before we go today, I want to remind everyone that we have the survey that is available to you when you log off. It is really helpful when trying to design webinars that we all want to watch. So if you could take a moment to fill that out, I would really appreciate it. And then I did want to highlight 2 upcoming webinars. I'm working on finalizing a date for this one, but this is going to be understanding lab tests for CLL. This will be with a CLL specialist. The one that I believe is going to be helping out with it is from the University of Nebraska Medical Center. And then on July 3rd, I'm going to be doing a patient story event with a patient advocate who is actually a myelofibrosis advocate or myelofibrosis patient, but she's published books about living with chronic cancers. And in conversation with her, I think that this will be a really beneficial one for any individual that's living with one of these chronic cancers. So I just wanted to highlight that one for this community as well. Even though she's not a CLL patient, she's a wonderful person, and I'm sure this will be a great webinar. And then, as always, I'm working on getting even more scheduled. So I will make sure that everyone knows about those once they're ready. And then, as a reminder, if you want to stay on and chat, I will keep the Zoom open. We'll close the live stream and close the recording, but I will be staying on if anyone would like to stay on for a little bit to chat with me or to chat with anyone else in attendance today. And then one more special thank you to our CLL Central sponsor, AbbVie. We wouldn't be able to do this type of work without them. And a big thank you to everyone for joining today. It truly means so much to me that you all decide to spend your time with us, either in person or I guess via webinar or watching these recordings. It's a very fulfilling job that I have, being able to help out the community in some way. So I thank you all for being part of this community. And if you ever want to speak with me, have any ideas for webinars or just any questions about HealthTree or just someone to chat to, my email's up on the screen here. I'm always available to members of the community. Feel free to reach out to me at any time. And with that, I hope that everyone has a great rest of your day. If you would like to stay on, I am going to go ahead and close the recording now as well as the live stream. So give me just one moment to do so.